Let's move on to talk about treatment of patients who have active myeloma by conventional criteria. And maybe we'll ask Harry, you to kick us off. How do you treat your newly diagnosed patient today? Yeah, well, let's define that as, we'll start with the younger patient.
So a newly diagnosed younger patient, almost always we should think about a transplant-based strategy to get them into a deep remission as quickly as possible. So outside of a clinical trial, I would still recommend a 3-drug induction with bortezomib, lenalidomide, dexamethasone. Sometimes there are exceptions if a patient has renal failure or cannot get lenalidomide on time because of insurance issues or something which are practical issues in the US only. They need to go on a 3-drug induction with cyclophosphamide substituted for lenalidomide and then switch over to lenalidomide as soon as possible. If they don't really get into a good response within the first 3 to 4 cycles, I tend to do a little bit of a response-adapted therapy, especially for those patients who I think need to get into a really good remission.
And what would you do then?
I would then switch over to a carfilzomib-based regimen, right, a KRD regimen, and then take them to transplant. If they still don't get into a VGPR before transplant, I would just transplant them.
Okay.
And
Noopur, you sort of invented the VRD light regimen. Do you use that in your elderly patients?
I do tend to use a 3-drug combination even in the older patient population, and I think it's important. You mentioned RVD light, so as long as you dose adjust, I do believe that most patients can still tolerate a triplet.
And what about you for the younger patient? Are you using carfilzomib or bortezomib up front?
There is data with carfilzomib, lenalidomide, dexamethasone combinations, as you know. This is all phase 2 data, and the data looks pretty good. There is a head-to-head comparison of RVD versus KRD also. This is the ECOG trial. We still don't have data with that, so depending on whether one is better than the other, we may preferentially use this. But I do tend to agree with Hari because there are certain patients where you will use risk-adapted treatment, very high risk, very young patients, and in the context of a clinical trial, I have used KRD.
So let's talk about high risk. Bob, you come in, you're a high risk patient, deletion 17, T414. What's your induction strategy with that patient?
Yeah. Well, I would actually push back a little bit on Hari about the transplant part of things, because we have data that were published earlier this year from the IFM Dana-Farber study on the French side that showed that for the group that got VRD induction, had stem cells collected but didn't go to transplant, had some VRD consolidation and then len maintenance, if they were MRD negative, they did just as well as the people who got to MRD negativity after a transplant. So that would suggest, not prove, that if you're good risk, I wouldn't do this for high risk people, but if you're in the good risk group and you get to MRD negativity, it would be reasonable to give them a choice of either harvest and hold or harvest and do the transplant. For high risk, which is what you asked, I think that's more problematic because these are people who need a much deeper response, and I think there's actually good rationale for proceeding with a transplant even if you're MRD negative there.
Let's, I want to come back to 4-drug inductions in a second, but let's just deal with the transplant issue. So Bob's saying if you're MRD negative, you don't need a transplant. Noopur, what do you think of that?
So I'm going to push back a little bit there because, you know, the MRD testing was done a little bit later. So they had the luxury of looking back. I think it's really important for the audience to understand is that everybody needs to be collected. Somebody who's transplant eligible, until we get this data out there, collection is really important. Withholding treatment could be all right, but that MRD negativity was at an 18-month time point, and you're looking at transplant pretty early after 4 to 6 cycles of treatment. So as of right now, the standard of care is still transplant if you're transplant eligible based on the data we have.